Alright guys, we're going to go ahead and get started with our panel discussion for tonight. We're very fortunate to have three very amazing physicians from Indianapolis that do a lot of work globally as well. And we're also fortunate to have Matt McGregor, Timmy's executive director, with us tonight. I'm going to let Matt actually introduce our speakers, as well as what exactly Timmy Global Health is and the organization. So thanks for coming. Welcome our panelists.
It's wonderful to be here. I'm hoping I'm not going to yell into this lapel mic, so if I'm too loud, someone please go like this. My name is Matt McGregor. As Zach said, I'm the Executive Director of Timmy Global Health, and I'm very happy to be here for a number of reasons. First and foremost, because I'm sharing the stage with three people that I respect a ton, that I think it's very, very fortunate that you guys have a chance to hear from. Secondly, I'm really thrilled that Marian has a Timmy Global Health chapter now. How are we doing there? That's okay. I'm very thrilled that Timmy Global Health has a chapter. As Zach said, I'm going to talk a little bit about what we do to give you a context here. Really what our core mission is as an organization is to empower the next generation of healthcare professionals to fight health disparities. That sounds really vague, but we try to do it as specifically as possible. We try to get a whole generation of people. Cell phones, apparently. So what we try to do is get a whole generation of future healthcare professionals to understand the ways in which they can transform lives and alleviate health disparities around the world. We do it in a number of ways. We send medical teams abroad, and we send our student chapters with those medical teams to be able to confront the challenges, the global health challenges that we talk about in classrooms like this all the time very directly. Zach, hold on one second. We're going to try to start this. How about that? All right. We send our students with our medical teams around the world so that they can confront challenges very directly, but we also ask those students to do things like this, to fundraise, to advocate, to serve on their college campuses in order to enhance the dialogue about today's most pressing global health challenges. We really believe deeply that it's this generation of healthcare professionals that are going to go on to confront some of the most difficult, pressing, intractable social problems around the world. And we want to be a part of that. So Timmy works with approximately 45 college chapters all throughout the United States at professional schools, medical schools, undergraduate campuses to try to get them to understand what they can provide and what they can do to have an impact on global health. So I'm absolutely thrilled to be here. I want to say a huge thanks to Zach. Zach is the person who introduced me, but he's also a Timmy student from one of our undergraduate chapters, and he spent a year living and working with us with our partner organization in the Amazon basin of Ecuador. It is very much a representation of what we're trying to do, which is find passionate, talented students who care about these issues and find ways to connect them to them. So, Zach, appreciate you guys inviting me here tonight. What we're going to do tonight is a couple things. I'm going to have the panelists talk about their work and how they've interacted with global health throughout their careers for very briefly, for about 5 minutes, and then we're going to have a conversation and open it up to you guys quite a bit about what it means to be a global physician and all the themes that come along with that. I'm going to lead that discussion and moderate a little bit, but I would love to hear from you guys. So at any point when I'm asking questions, if you have a question, just raise your hand, I'll get you involved, and hopefully we can create an open dialogue and a conversation here. So thrilled to be here. Thanks to Zach again, and I'm going to introduce our first panelist, which is Dr. Raj Sood.
So, can you guys hear me without this thing? Yes? No?
How about now? So, as Matt mentioned, I'm Raj Sood. I'm a professor of surgery at IU. I'm the chief of plastic surgery, which is my area of specialty, and it's divided into doing burn surgeries. I run both the adult and pediatric burn centers at Eskenazi and Riley, and I do a lot of cancer reconstruction, breast cancer, and then finally I do some cosmetic surgery as well. So I'm pretty lucky to have what I consider a great practice in an academic environment. I became chief of plastic surgery at IU about 6 months ago. And again, I feel very blessed to have that position. Not most of us in academia have to move to get positions that we sort of strive for. And so I was lucky to be able to get that. So my interest in global health sort of emanated from my background. I was born in England, lived in India. I'm of Indian origin for about 7 years, and then moved to the United States. And my parents were physicians. They're both deceased now, but very early they sort of, and all three of the boys, I have two younger brothers, sort of taught us that you're going to learn, you're going to earn, and then you're going to return. And sort of this philosophy of learn, earn, and return was something that became a very integral part of all of our lives. And my brothers are surgeons as well. And so I did 8.5 years of training after medical school in general surgery, plastic surgery, hand and microsurgery, and then congenital hand surgery. And then I started at IU in 1992, and I've been there since. And literally my first year out of training, I chose to start mission work. And it's something I'd sort of told myself that if I was blessed enough to get into medical school and do what I've always wanted, that I would give back in that way. And so, not having grown up in India, I started my mission work in India. We would do week-long mission camps with an amazing person named Dr. Dikshi, who would pick American surgeons or American trained surgeons, take us to India, and we would go to different sites all over India and essentially do congenital plastic surgery. And I did that for about 10 years, till about 2002. And it was very rewarding, and for those of you who have gone on a week-long mission trip, you know how exciting it is. It's great, you can impact some lives, it's good for you, it's good for the patients you help. But as I started to continue, and as I got older in my practice, I sort of realized that it wasn't quite fulfilling for me, because I felt like I would I would operate on 40 or 50 kids, but then I would come home, and literally within a week that high goes away, and I didn't know if I'd made an impact on global health. And I very much thought that, at least from my perspective, one should pick an area of global health to affect. And so in my case, being director of the burn centers and having done burn surgery at IU for now 20 years, I chose that as my area of focus. And just at that time, Chuck Dietzen, who's the founding physician of the Timmy Global Health, came to me and actually brought some visitors from El Salvador. And this was actually the president and first lady, and we had just built the new burn center at the old Wisher Hospital, again about 8 or 9 years ago, and they wanted to see it. They came, they saw it, and they asked me if I would help build a pediatric burn center in El Salvador. So I said, yeah, that sounds great, sounds like a sustaining thing or a sustainable thing, so let's go look at it. So Chuck and I went down there, and I wasn't on the Timmy board at the time, and we just did what I call an infrastructure assessment, which is critical when you're trying to do, particularly I think if you're doing global health in a medical related field, and you're going to build something, you have to do a needs assessment. So first of all, we decided, yes, there's a problem, because children with a 25% burn were dying, whereas at Riley, the LD50 for burns is 92%. So there was a huge disparity in survival. So we thought, yes, there's a problem. Then we looked at the numbers. There were, at Riley, we admit about 250 kids a year. In the El Salvador and Bloom Hospital, which is the only pediatric hospital in El Salvador, they see over 1,000 kids with burn injuries. There was no burn prevention at the time, so we, because we were with the president's office, gave us a lot of instant credibility. We met with the Minister of Health, we met with the president of the hospital, we got instant support basically, and that's one thing you absolutely need when you're doing mission work and you want to impact global health, in my opinion. So anyway, we started the first year, I think it was 2004, we took our first team. And the other thing is that, I don't know if any of you have been involved with burn care, but it's a multidisciplinary approach. It is not just physicians. In fact, a physician alone couldn't provide the burn care. It's nurses, therapists, psychologists, so it's really a multidisciplinary team. We make multidisciplinary rounds. So we took 20 people on that first mission trip for a week. And we basically went there, we operated, we had all our protocols translated into Spanish, and we basically started interacting at each level. For example, my partner and I, another surgeon, we trained the plastic surgeons that were there. The nurses trained the nurses, the therapists trained the nurses. So at every level, the OR team trained the OR team. We basically tried to not make them treat burns like we do in America, but basically fit what we do, things that we know help survival, such as treating the patient early, and try to imbue those characteristics in their philosophy. And so we repeated that, and the nice thing was we did that for a week. We operated on basically anything they would give us. Pediatric cleft lip, pediatric hand, pediatric burn reconstruction. We see things in El Salvador that you would never see in the United States. A child with a cleft lip in the United States gets treated at 3 months of age. You probably have never seen an unrepaired cleft lip here. We've never seen it. So, but I've operated on adults in El Salvador with cleft lips. So it is a very resource-limited country, as are most of these other countries. And so what we did from that point on was to go back every year. So we gave them our word that we would provide infrastructure support. Now, what does that mean? Well, that means that you can't just go for a week and then assume that everything will happen that way for the next 51 weeks. It also doesn't mean that you can provide them with technologies such as artificial skin, which we would bring them from here, and just leave it there. So we had to sort of develop this telemedicine approach to allow the plastic surgeons or the therapists or the nurses to be able to communicate with their counterparts here at IU so that we could have a dialogue all year long, so that it's just wasn't just for that 1 week. And then they felt that they were supported. Okay? We also insisted that everybody we operate on would be seen the following year. So we would have follow-up for our mistakes. And I think building a QA, quality assurance, quality improvement program within your mission experience is very important, particularly in surgery where outcomes are, here they're measured daily, weekly, monthly, and we have to report every complication. But in El Salvador, that's not really true. But for us, we felt that we didn't want to just go in, be the Americans that are operating on patients there and not worry about it, and let them know that we truly cared for these kids. So some of these kids now we've seen for 6, 7, 8 years in a row. We've gone back every year. The other, I don't know, am I running out of time?
Yeah, about a minute.
Oh, okay. So let me speed it up. We were fortuitous enough to meet a guy named Dan Meehan, who was a billionaire and had traveled through El Salvador and had met a kid who would actually survive somehow a 70% burn. And on a piece of napkin, this guy wrote, if you can provide the infrastructure and the training and all, I will donate $1 million to build a pediatric burn center. So I got introduced to him. I told him that I would design it. We had just built 1, 2, and now 3 burn centers in the United States here at IU. I told him I would do that. We got our architects to design it. We provided infrastructure. We provided equipment for them. We raised money. He gave the $1 million. And 2 years ago, a new pediatric burn center opened in San Salvador. And so that was great. He's very happy. We operated there last year for the first time. There are 2 operating rooms built into that burn center. And that burn center, if you walked into it today in El Salvador, is no different than the new 35,000 square foot Eskenazi burn center that just opened a month and a half ago. It's essentially got the same equipment, the same capabilities. So very excited. Just in my last 10 seconds, we've been asked to build a burn center in Panama as well. We've been to Panama to do mission work, and the government there is a little bit of a different situation because of the canal. They have a lot more money. And we are going to be working in Kenya. We've been asked by Dave Matthews, who's the surgical counterpart of Dr. Einterz, to help build a burn center in Kenya as well. So that's my story.
Thank you, Dr. Sood. And with the next person would be Dr. Bob Einterz.
Well, thanks again for inviting me here to speak with you. I'm really excited about your school. I think it's terrific, and I'm looking forward to seeing you develop. I should put a little disclaimer. Sister Norma and I go back a long way. So I don't even know if you in the medical school know who Sister Norman is. Do they know you, Norman and Sister? Yeah. Anyway. So, I'm kind of like Raj, I guess. The influence for going into this field that we call global health, I think, came from my parents and from a couple of my siblings. And I'm sure that our motivation is probably not a whole lot different from those of you here in this room, in that you, like we, think that we have been given some gifts and some privileges, and we have perhaps even a duty or an obligation to share those with others. And so I think it's a very common motivation for those of us who do engage in global health. I guess I should say here at the outset that when I use the term global health, I'm particularly talking about trying to reduce disparities and assure access using a multi-sectoral approach, working across disciplines. And global health for me is not defined by political boundaries. One can practice, if you will, global health or do global health in Hawville, which is on the other side of White River, just as much as one can do it in Ecuador or Kenya or any other place around the globe. So I cut my teeth, if you will, in global health, working in a Native American reservation in North Dakota after I finished my senior year in medical school. And then I had a short-term experience working in Peru, and then I worked for a year after I had finished my residency in general internal medicine, finished my chief residency. In fact, took a year's leave of absence from the faculty of Indiana University, and worked on a primary health care program in rural Haiti. I dragged my poor wife and our 2 children at the time, both in diapers. One was just short of 2 years and the other just short of a year, and dragged them to an area without electricity and running water. I was excited. It was a little bit of a challenge for my wife. We had a bit of a traditional relationship back then, and so the dirty diapers got to her and got to me, I guess. But it wasn't quite that bad. Help was cheap. But that was a wonderful opportunity for both of us as a family. And I was responsible for both educating community health workers working in a dispensary/health center, and then running with Haitian colleagues a primary health care program, immunizations, oral rehydration, growth monitoring, this sort of thing. I then returned back to Indiana University and with 4 of my colleagues founded the relationship between Indiana University and Moi University in Kenya. That relationship has endured over the last quarter of a century now, and I've had responsibility for coordinating that. We, with another colleague, founded this thing that we call AMPATH, the academic model providing access to health care. I won't go through all of this, but in a nutshell, we, Indiana University, worked with our Kenyan colleagues to bring up Kenya's second medical school, and then in partnership with Moi Teaching and Referral Hospital and the Ministry of Health in Kenya, we have developed a system of primary health care and HIV control that serves a population of about 3.5 million people in Western Kenya. And this has been a relatively successful program, particularly in controlling HIV, reducing the incidence of HIV transmission from mother to child, reducing community-wide incidence and community-wide viral load. And in this program, of course, we take a very comprehensive approach to healthcare delivery and systems development. We address the social determinants of health, which, as you all well know, tend to be more important determinants than the biomedical determinants that we learn about in our first year of med school. So though I wear a stethoscope around my neck, and in many ways I'm more involved in things such as income security and food security, farming, and sack gardening than I am perhaps in putting a stethoscope on somebody's chest. So I do a little bit of all that, though, and so in a nutshell, that's me.
Thank you, Dr. Thank you, Dr. Einterz. Our last panelist is Dr. Mercy Obeime.
Hi, everyone. Can you hear me? Just wave your hand at the back if you can't. Okay, good. I can hear everybody. Well, my name is Wesley, and officially I work for St. Francis, but I consider myself really blessed because from the first day I started working for St. Francis, almost 18 years ago now, I requested that they give me some time to work with the community, and somehow I kind of got them roped into agreeing to do that in my contract. And they assigned me to work with Dr. King, and the rest of it has been doing what I want. Anyway, so as Sue said, you know, my grandmother, who was not educated, I talked about her in 2011 when I did the commencement speech. I wear this necklace because of her, because she's actually the reason I'm here. Can you hear me? Can you hear me now? Yeah. And well, I went to a school for gifted children in Nigeria. So about the age of 16, I was questioning everything. I grew up as a Catholic. I lived with the nuns all the time. And then I went to a school for gifted children. There were other kids from all the religions. We had kids from the north who had never gone to school. Everybody had a whole lot of different things. So at 16, I'm kind of just not really wanting to do anything that everybody really wants me to do. And I wonder what my children are like that today. But anyway, I was talking to my grandmother one day about what I was doing, and she just said, I don't want, my pastor wants me to do accounting or law, and I told her why I didn't really want that. And they said, well, you know, you're so disorganized, we don't think you can do medicine, but that's probably something you can do. And I think just because she said that, I thought, how dare she think I can do something? So I thought, okay, I was going to drop physics, and they said, you can't go to med school if you drop physics. So I thought, fine, I'll take it. Anyway, so I'm talking to my grandmother. She doesn't know what any of this means. And then she says, well, tell me about all these things they're trying to tell you to do. I tell her about finance. But in Nigeria, if you do finance, you're going to have to steal money. You're going to help people steal the oil money and get rich. She didn't like that idea. If you're a lawyer, you're going to have to defend thieves or something. Otherwise, you will not have any money because more people have no justice. And then I was talking to her about medical school, and then I said, you know, she knew about the sisters because there was a hospital there, and she'd never really been to the hospital, but she knew once they saved actually they saved my mother because she had like 4 children back to back. They had died, and somebody took her there when she was pregnant with my mom, and she had my mom. So she liked the nurse and she liked the hospital. So I brought up this hospital thing. And she stopped me. She said, you know what? I like the hospital thing. Because if you go and work in the hospital, you save people like somebody saved your mother. And that's good. What can be better than that? It doesn't matter how much money you make. It doesn't matter. You should do that. I'm like, okay, Donna, that sounds good. I'll do it. So I went back to school, picked up physics, and decided I'm going to go to med school. I didn't know what I was doing, so I went. And so I went to med school. Went through med school, met my husband towards the end of med school. Again, I wanted to be out of the norm. In Nigeria, women technically had a very traditional role. It's changed a lot now. If you're married, your husband spoke, you couldn't speak, and I didn't even date really because I just didn't want to be seen as somebody's subordinate or anything. So I was not want to do that. So then I decided, well, I'm not going to get married. I'll just do medicine. I'll go join the Navy. And one day I'm walking my grandmother home. We passed this house, my husband now, we passed his house. I come from the US to visit. And he's talking with his brother and says, who's that girl? You don't want to talk to her. She's rude and she's too skinny. She doesn't talk to anybody here. She thinks she's too rude. She only talks to she teaches the kids, but she won't talk to any of the young guys. His brother had a car, and I made him give me a ride a couple of times, but I didn't want to talk to him. He was just getting from point A from point B. I didn't say I wanted to do anything else, so he didn't like me very much. Anyway, long story short, I came to the US, had to do my exams to practice. I hated it. I don't like studying very much. So I did my exams, I passed, and then I did my residency, and I was going to get a job. During that time, I knew about Africa. I really wanted to go to Africa because we were doing that's what I thought I would do it. But then as I was looking, this some of that you had to go to Kenya. I had 3 young children. My husband was in residency. I couldn't do it. I thought, forget it, I'll just do something else. So I got a job. So I was doing a surgical rotation with a surgeon there, Dr. Strange, where I love him. And I did my rotation with him, and I had a couple of patients who couldn't afford care, and I was talking about them, and he decided to do surgery with them. So I'm finishing my rotation, he says, you need to walk us St. Francis. What do we got here? He says, yeah, this would be great. And then he says, we call this number in 1996. That was when hospitals were buying up all primary care. So all you needed to do was talk to some sick person in the PPA practice. You didn't have to see it. And I didn't like that. I just don't like falling in line and following everybody. So Dr. Strange says, call this person. I call her. She says, well, we don't have anything. I'm like, great, thank God I don't have to do this. So I'm still wondering what to do with the rest of this. And then the next week, I go to Dr. Strange. She says, did you call this person? She's a good friend of mine actually. I said, yeah, I called her. She said, they didn't have any open. I said, really? I said, yeah. Well, a few days later, I get a call from Mr. Lee. Mr. Lee is like the #1 person at St. Francis now. Then he was our CEO. So he engages me actually. So I answer my phone. He talks to me and he says, this is Mr. Lee. I'm like, how can I help you? Because I'm calling from St. Francis. I got a number from Dr. Strange. I would like to have lunch with you. Who is this? So anyway, it turns out Mr. Lee is the CEO. I have lunch with him. He says, Dr. Strange says we need you in our system. You have a job if you want it. Then I checked and I found out he's the CEO. Why does the CEO have lunch with me? I can't even talk to the doctors I'm going to be working with in these other places. So I decided, okay, they were paying me the least too. So I said, I'll take this job. And then after that, I said, where do you want to stay? I'm thinking, oh, I hadn't thought about that. Where do you need help? So they're telling me where they have the clinics. I go, don't you have any on the north side? I said no. And then the furthest, furthest north, they would say, the one I was closest to my house, basically I'm looking to see how am I going to drop my kids off, pick them up, get home and all of that. So they go, oh no, you were referred by Mr. Lee, we don't want you to go there. I said, why is that? Well, that's why the poorest people in the system are. We want you to go to one of these new places. I said, no, I like to walk. I said, that's where I want to be. It's close to my house. And so they're like, no. And I said, did you say you were going to pay me a salary? And they said, yes. I said, so what's the problem? If they don't pay and they're paying me, they're evil. So anyway, I got that job. And so I'm taking care of people and just doing my thing. And then somehow, using my relationship with Dr. Kane and everybody to beg and Byron and do all kinds of stuff. So patients there didn't have much. I would say, well, you live in America, yeah, we can go to Michelle. And basically, we'll just run people back and forth to beg and whatever they want. I never knew at that time that there was going to be no poverty in this time. Because I wish the patient came into the system and they were poor. As a resident, I didn't really see them. The social worker took care of all kinds of things and I didn't see it. So it just kind of went normally for me. But at the clinic, if they were poor, that probably meant they're not eating, they have no medicine, they didn't have this. Where are the social workers? We didn't really have that robust system. So now fast forward again, in I think it was 2002, I'm getting all of these recognitions. Since I nominated me for something, I win a national award, so people think I'm doing all this stuff. And then one day I sat down and I'm just thinking, this is too easy, I'm getting ready, I'm not even doing anything. All I have to do is sign a piece of paper. And these things get done or somebody does, I'm getting credit for it. This is not right. I need to go home and I need to go get these folks in Nigeria. I'm wondering that God, knowing that my husband will probably say no. Then I get called to a meeting to meet with Obeime or Christopher. I didn't know who these people were then, not really knowledgeable about entertainment world. So I go to a meeting with them, I'm telling my husband who I'm meeting. We go to the meeting and they're talking about AIDS in Africa. I tell them how they want to help, they want me to be at this committee working with them. And I say, okay. And then I listen to them talk about how it's so bad in Nigeria and Africa, and they're doing nothing about black, the only African in the room, the only black person in the room, and black people. Okay, they're not. It's a shame. These people are here fighting for my people, not here being comfortable and getting about this credit for it. And when I know that, I told my husband, I have to do something. It's crazy. We have these kids, and the rest of us says, I don't really care about you right now. I said, I'm going to do this. I feel horrible. I just cannot. I mean, for some reason, the incident happened that day. I think I'm not really that one depressed by the past. So I always say that my involvement prevented me from being on SSRIs and tobacco. Because every time I think I'm getting good, I go on the mission and I cry when I come back. So, so that's my skill.
Well, thank you guys so much. the questions that I'm going to start with and that I'm going to use to moderate the panel come from you guys. So please continue to shout them out. Just raise your hand and I promise that I will call on you. I'm going to make a quick announcement here that I know Dr. Sood has to run a little bit earlier, around 6:30, so Raj, whenever you need to, just get up and go. But I'm going to ask a few different questions to start. One of the things I want to ask is this idea of something you said, Raj, I think that was really amazing, is that you said that we have to fit what we do into their context and philosophy. And you talked a lot about this idea of going and working with a local hospital and a local organization and having to modify what you do and fit it into their context and their philosophy. I wondered if you could expand upon that.
I think it's very important. We as Americans simply have to travel overseas and provide health care to realize how fortunate we are. Mercy said you can be quite poor and walk in and wish it. Well, here's the deal. You could walk into the IU hospital and request a plastic surgeon and you would get me. You could walk into Wishart with no funding, nothing, and I don't really care, and you ask for a plastic surgeon and it would be me or one of my 10 partners. And so that is not true where we go, okay? When we go to El Salvador, there are 100 or 150 children born with cleft lips. Only about 30 or 40 of them will get operated on. You know why? They don't have the suture. They don't have the OR time. They don't have the structure to do that. So for example, when we go and we do 50 or 60 kids in a week, that's a big chunk of their waiting list for the year. But what you can't do, and what I realized in my early mission work, was just going there and this is the way we do it. Well, you had to modify everything. As I said, we modified our protocols. We sort of took in the terrain and said, well, look, these are dressings we use, but this dressing is, $500, and in America it means nothing. Well, in El Salvador, that would be their, GDP. So the reality is that you have to be very careful with what you bring in, and you really have to adapt, and you have to change your thinking. And that's what I learned, that you could do so much with so little. And literally, when you come back here, it's a sensory overload with what we have. And actually, if you just take a look in the operating rooms at what we throw away, you would be amazed. You would be amazed. And they throw nothing away in El Salvador or Panama or India. They recycle everything. So really, your thought process has to be very